Welcome back to the Deep Dive. We're here to sift through compelling research and really pull out the insights that matter for you. So let me ask you this. Have you ever been part of an organization, maybe even just, trying to start a new habit yourself, where a really great idea, a new way of doing things, it just fizzled out?
Oh, absolutely. Happens all the time, doesn't it?
Yeah. Despite the best intentions, maybe even good training, everyone seems on board, but it just struggles to stick in the real world. It's so frustrating.
It really is.
Well, today we're diving deep into a paper by Lewis, Scott, and Marriott from 2018. They outline this really fascinating practical way to tackle exactly that problem. Think of it as a guide, like a step-by-step manual for creating a custom-tailored implementation blueprint. The whole point is making sure new practices actually integrate and last.
Yeah, moving beyond just hoping for the best.
Exactly. It's about being systematic, strategic about change.
And this is just so critical because, as the paper points out, the traditional ways we've done this, maybe just training plus some consultation, well, they often fall short.
Right. They don't quite cut it.
No, they don't get that full integration, that long-term sustainment, especially when you're talking about complex places, like the example they use here. Residential treatment centers for youth, very dynamic settings.
Makes sense.
So the authors, they really want to open up what they call the black box of implementation tailoring. Basically, show us the detailed process, how you actually customize strategies for that specific place instead of just using a generic plan.
Okay, so what's our mission for this deep dive then?
Our mission is to unpack the specific methodology they developed. We'll look at how they created a tailored blueprint for implementing cognitive behavioral therapy, CBT, in this youth residential setting. It involves first identifying the specific determinants, basically, the local barriers and facilitators, and then matching them with targeted strategies. It's about going from what to do in general to how we do it right here, right now.
Got it. So it sounds like the absolute starting point is really understanding the ground truth, the specific environment. How did this team make sure they were truly getting to the bottom of what helps or hinders a new practice like CBT?
That's the foundation, exactly. And it starts with their step one, needs assessment data collection.
Okay.
And this wasn't just like a quick chat. They used a really robust mixed methods approach.
Mixed methods, so combining different types of data.
Precisely. They used quantitative surveys, getting the numbers on things like attitudes, resources, and qualitative focus group. That's where you get the rich details, the stories, people's experiences in their own words.
Ah, okay. Numbers and narratives.
Exactly. And to give it structure, they used a common framework from implementation science, the framework for dissemination. Think of it like a lens. It helps organize all that info by looking at 6 key areas, things like norms and attitudes, resources, policies, communication.
Those make sense of the complexity.
Right. And they applied all this at Wolverine Human Services, which is a large residential youth center in the Midwest. They were looking specifically at 2 programs there, one non-secure, one secure, both trying to implement CBT.
Now, something I found really interesting was who they talked to. They didn't just focus on the mental health therapist, who you'd expect to be the main targets, right? They also brought in operations staff, youth care workers, shift coordinators. Why was that so important? It feels like a bit of a departure.
Oh, it's a critical departure and such a smart move. You're right. Traditionally, the focus might just be on the clinicians delivering the therapy. But the paper argues, and I think rightly so, that in a place like Wolverine, if you exclude the operations staff, even though they aren't the ones doing CBT, you could seriously undermine the whole effort.
How so?
Well, these are the people on the front lines 24/7, right? Managing routines, interacting with the youth constantly, setting the tone on the units, their buy-in, their understanding, their support. It's absolutely essential.
Okay, I see. If they don't get it or don't support it, they could inadvertently work against it.
Precisely. You'd be missing a huge piece of the environmental puzzle. Any progress made in therapy could just get eroded if the day-to-day environment isn't aligned.
So this whole mixed methods thing, digging into numbers and stories from everyone involved, that sounds really thorough.
It is. They weren't just getting surface-level opinions. They were uncovering the nitty-gritty, the day-to-day realities. But, okay, you gather all this data from surveys, from focus groups, from different types of staff.
Yeah.
How do you actually make sense of it all? Turn it into something you can act on?
Yeah, that sounds like the next big challenge. How do you synthesize it?
That brings us to step 2, mixed methods analysis. They used what's called a Q&M plus QLL structure.
Q&M plus QL.
Yeah, basically means they use the quantitative data, the numbers, to sort of confirm general trends or patterns. Then they use the qualitative data, the focus group stuff, to expand on those findings, to get the why behind the numbers.
Okay, so confirm with numbers, then explore the why with stories. Makes sense.
Exactly. It's like confirming a fever with a thermometer, then asking the patient how they actually feel, what their symptoms are like.
Gotcha. And they were looking for specific things in this analysis.
Critically, yes. Their main focus was on identifying the barriers, the things getting in the way, because those are the issues that you need to develop active strategies for.
Right, you need to know what problems to solve.
Mm-hmm. And the result, well, it was pretty staggering. This deep dive uncovered 76 unique barriers to implementing CBT just within this one organization.
76. Wow.
Okay.
That sounds overwhelming. Like, where do you even begin with that many roadblocks?
Yeah, it absolutely sounds overwhelming. And honestly, that number itself is a huge finding. It shows you why just doing, say, a weekend training often isn't enough, right?
Yeah, clearly.
There are so many context-specific things going on under the surface. You can't just throw a generic solution at 76 unique problems. Trying to tackle all of them at once, forget it. You'd burn out your resources and your people fast.
Okay, so prioritization must be absolutely key then.
Utterly critical. And that leads us neatly into step 3A, barrier prioritization.
How did they do that? How do you pick which of the 76 barriers are most important?
They used a really clever technique, borrowed from other fields actually, called modified conjoint analysis.
Sounds complicated.
But the way they did it was actually quite elegant and surprisingly low tech, very accessible.
Oh, so.
They literally wrote each of the 76 barriers on a simple 3x5 index card. Then they got the agency administrators together.
The decision makers.
Right. And they gave them a big 2x2 poster board grid. The administrators had to place each card on this grid based on two things: how feasible they thought it was to change that barrier, and how important addressing that barrier was for CBT to succeed.
Ah, okay. So feasibility versus importance, like a classic prioritization matrix.
Exactly. So, for instance, a barrier like staff lack knowledge about CBT. Well, administrators rated that high on importance and pretty high on feasibility. You can train people. So that became a top priority.
I like that. It's practical, visual, collaborative.
Totally. And this process, it really helped them narrow the focus. They went from that daunting 76 barriers down to just 23 prioritized ones.
23. Okay.
Yeah.
Still a lot, but much more manageable than 76.
Definitely. It allows for focused effort. And this step is just vital. Like you said, it forces those strategic choices when resources aren't infinite.
So you figured out what the priority problems are. The next logical step has to be figuring out how you're going to fix them, right? What strategies to use.
Precisely, which takes us to step 3B, implementation strategy selection. Now they have their focus list of 23 barriers. Time to find the right tools.
Did they just brainstorm solutions?
No, they were systematic about this too. They didn't just make things up. They drew potential strategies from a published list, a compilation of 68 distinct evidence-based implementation strategies. Think of it like a well-stocked toolkit of things known to help implementation.
Okay, so they're using established methods.
Right. And the selection process was, again, really collaborative and data-informed. The stakeholders there at Wolverine, they rated the potential strategies based on feasibility. Realistically, can we do this? What's the budget? Do we have the staff time?
Practical consideration.
Very practical. At the same time, CBT experts and the researchers involved rated each strategy on its likely impact. How much difference is this strategy likely to make in terms of improving CBT fidelity? They used a simple scale, 1 for low impact, 3 for high impact.
So feasibility from the ground, impact from the experts.
Got it. Strategies got selected if they scored high on impact or high on feasibility, or ideally, of course, high on both.
Makes sense. You want things that work and things you can actually do.
Exactly. And then, critically, they matched the selected strategies directly to those 23 prioritized barriers. So strategy X is chosen because it addresses barrier Y. This careful matching process resulted in a final set of 36 implementation strategies. These became the building blocks of their blueprint.
Okay, so we've got the prioritized problems, we've got the selected tools, but tools don't use themselves.
Yeah.
A blueprint needs builders,
Yeah.
right? Who is actually going to do all this work? Putting the plan into action must have been the next piece.
Absolutely crucial. A plan is just paper without people to execute it. And that brings us to step 4, implementation, team formation.
Ah, setting up the teams.
Yep. They created 2 dedicated implementation teams, one for each of the programs involved at Wolverine. Each team had about 10 members.
And how did they pick these members? Just volunteers?
No, again, very strategic. They specifically look for people identified as opinion leaders. The folks whose views colleagues tend to respect and follow, and champions people who already showed a positive attitude towards evidence-based practices.
How do they find those people?
They used specific tools, sociometric surveys, which kind of map out influence networks within the staff, and an attitude scale, the evidence-based practice attitude scale. So it wasn't just guesswork, it was data-driven selection of influential and motivated staff.
Smart, leveraging internal influence.
Definitely. And they didn't just form the teams, they gave them structure. They created specific officer roles within each team to make sure things actually happened and kept happening.
Officer roles, like what?
Things like a chair to run the meetings, a secretary to keep records, a program evaluator to track how things were going, an incentives officer, I like that one to focus on team morale and recognition, and a communication officer to ensure information flowed out to the rest of the staff.
Wow, quite formal, like a little project management team.
Sort of, yeah. And their goals were clear. These teams were responsible for overseeing how the strategies were put into action, for becoming the go-to in-house experts on both CBT and the implementation process itself, and even for brainstorming new strategies if needed down the line.
That emphasis on internal ownership, involving staff from different levels, giving them real roles, that sounds incredibly important for making it stick. But how hard is it, really, to get that genuine buy-in, especially when you're asking, say, operations staff to get involved in clinical implementation?
Oh, it can be really tough. And that's why this structured approach, this inclusion, is so vital. By bringing everyone in, therapists, operations staff, and giving them formal roles, real responsibility, the blueprint stops being something pushed onto them from outside or from the top down.
It becomes their plan.
Exactly. It shifts from they want us to do this to this is our plan for improving things here. That sense of shared ownership, tapping into that intrinsic motivation, that's gold for long-term sustainment. Without it, like you said, even the best plan just won't fly.
Okay, so the teams are in place, ready to build. What does the actual blueprint look like? How do they pull all those barriers and strategies together?
Right. This is step 5. Implementation blueprint creation. This is where everything comes together, the barriers, the 36 strategies, the empowered teams into one concrete phased roadmap.
Phase, so not trying to do everything at once.
Correct. Very important. They organize the strategies into a 3-phase blueprint spanning 5 years. Phase 1 was pre-implementation, basically year 1, getting ready. Phase 2 was implementation, the core rollout, covering years 2 through 4. And phase 3 was sustainment, focusing on keeping it going in year 5.
5 years. That's a serious commitment.
It shows the level of effort needed for real change in complex settings. And across those phases, they mapped out 45 unique strategies in total. Remember, some strategies might be used in multiple phases. These strategies covered all 9 major categories you see in implementation science. Things like developing stakeholder relationships, training people, supporting clinicians, changing the infrastructure, even using financial strategies.
45 strategies across 5 years. Can you give us maybe a couple of concrete examples from each phase, just to, bring this blueprint to life a bit more?
Absolutely. So in pre-implementation, year 1, think foundation building. Strategies included things like developing stakeholder interrelationships, for example, literally scheduling and protecting time for biweekly implementation team meetings, crucial for communication.
Okay.
Also, training and educating, like selecting the specific training methods that fit the staff and context, supporting clinicians, maybe restructuring clinical teams for better CBT integration, and even modifying the context, like changing the electronic health record templates to make CBT documentation easier. Little things that make a big difference.
Right, laying the groundwork. What about the main implementation phase?
Okay, implementation, years 2 to 4. This is where the core practice change happens. So strategies here included the specific intensive CBT training and ongoing supervision, maybe from experts like the Beck Institute or Indiana University, as mentioned in the paper.
Heavy lifting of skill building.
Exactly. Also, holding cross-staff clinical meetings where therapists and maybe operations staff could discuss cases together, changing performance evaluations or job descriptions to actually reflect CBT competencies, and using train-the-trainer models to build that internal capacity, get more staff certified.
Building self-sufficiency, and then sustainment, year 5.
Sustainment is all about making it last. So strategies included things like continuing to engage the implementation team. Their job isn't done after rollout. monitoring fidelity regularly, maybe even randomly, observing sessions to make sure the CBT being delivered is still high quality.
Keeping the quality up.
Conducting educational meetings for new hires or refreshers for current staff, and continuing those the trainer efforts so you always have certified people internally.
It sounds incredibly comprehensive.
It really is. The blueprint served as this detailed roadmap. It clarified what needed doing, who was responsible, was it the internal team, was it external experts? And crucially, when things should happen. It's like a living document guiding the change over the long haul.
So, reflecting on all this, this methodology sounds incredibly thorough, very well thought out, maybe a bit demanding too. What do the authors see as the main benefits, the big takeaways for anyone trying to implement change?
Yeah, it's definitely thorough, but they highlight several key advantages over just, winging it. First, they argue that despite its depth, it's designed to be a relatively low-burden collaborative approach in practice, using simple tools like note cards involving staff. That helps.
Okay, accessible.
Right. It also really leverages the latest advances in implementation science using established models, strategy lists, measurement tools. You're not starting from scratch.
Building on what's known.
Exactly. It provides that clear, phased roadmap, which creates transparency and, as we discussed, fosters real stakeholder ownership because people were involved in building it. That's huge.
Yeah, that ownership piece feels critical.
It also allows for explicit cost mapping. You can see what resources are needed for which strategy, which helps with budgeting. And it ensures strategies are laser-focused on the unique, locally identified barriers, not just generic ones.
Tailored solutions.
Precisely. And fundamentally, it helps open up that black box of tailoring. It makes the process visible, systematic, and potentially replicable elsewhere, with adaptation, of course.
That clarity and ownership sound like massive pluses. But, as you said, no method's perfect. The authors were pretty upfront about limitations too, weren't they? Which is always good scientific practice.
Absolutely, and it's helpful for anyone thinking of using this. One major point is limited generalizability. This was done in one specific type of setting, a youth residential center. Applying it in, say, a school or a hospital would need its own deep dive, its own assessment.
Makes sense. Context matters.
Hugely. Also, the tailoring wasn't done for each individual program within Wolverine, the secure versus non-secure sites. Administrators wanted some standardization, which is understandable, but it might have missed some finer grain differences between the programs.
Potential trade-off.
Could be. Another point is the complexity. It resulted in 45 unique strategies. That's a lot. They acknowledge it's unclear if maybe a simpler, more parsimonious set of strategies might have worked just as well. Maybe fewer, really high-impact ones. That's a question for future research.
Right. Is more always better?
Good question. Also, the focus was heavily on barriers. They didn't spend as much time systematically identifying and leveraging existing facilitators or strengths, which could also be a powerful engine for change.
Interesting point. Leverage what's already working.
And importantly, the project was still ongoing when they published, so they didn't have the final long-term effectiveness data yet. We see the process, but not the ultimate outcome fully measured.
Yeah.
And one more subtle but important point. It's what they call prospective tailoring. It designs the plan upfront, assuming the context will stay relatively static, but real life isn't like that, right?
No, things change all the time.
Well, exactly. They even observe that barriers can pop up again later or new ones emerge. So implementation might need ongoing adaptation, not just a fixed 5-year plan. It needs to be more dynamic.
Like course correction.
Yeah. And finally, that low-tech conjoint analysis with note cards. Great for accessibility, but maybe slightly less methodologically rigorous than, say, specialized software. A minor point, perhaps, but they noted it.
Okay, that's a fair assessment of strengths and weaknesses. So wrapping this up, what's the core message for you, the listener? For me, this deep dive really showed a clear, structured, collaborative way to make change happen, moving way beyond just let's do a training, to actually building a tailored plan to embed something new for the long haul. It's about being really intentional.
I completely agree. And while this specific example came from a youth residential setting, the core principles, they're universal. That process of systematically digging into your specific context, identifying your unique barriers, and then thoughtfully matching them with tailored, phased strategies, that's valuable everywhere.
Yeah, it doesn't matter if it's a clinic, a company, a school.
Or even for personal change, arguably. It applies anytime you're facing a significant change or trying to make a new way of working stick. It's about understanding your specific landscape, not just trying to follow a generic map that wasn't made for your territory.
It really makes you reflect, doesn't it, on all those times we try to roll out something new software at work, maybe a new curriculum, even just like a new family routine.
Yeah.
This paper strongly suggests we need more than good intentions. We need that blueprint for success.
Exactly. This methodology really underscores that success isn't just about having the brilliant idea. It's about the systematic work of understanding the environment, prioritizing the real hurdles, and then designing that precise phased plan to overcome them. So maybe the final thought for you, the listener, is this. What area in your own work, or maybe even your life, feels stuck? Where could applying this kind of detailed implementation blueprint moving beyond guesswork to a truly tailored strategy make a real difference?
That's a powerful question to mull over. Thank you for joining us on this deep dive. We hope you feel better equipped and maybe inspired to tackle your next big change with a solid blueprint in hand.